Well, this is fun. For the record, and I want everybody to know that I'm more than 6 feet away and we have a fairly well ventilated area. I feel comfortable taking my mask off, having been recently tested and triply vaccinated. So, but I very much support medical grade masking indoors, as we do with the CDC, and all of us at the conference have been doing that. Thank you very much. One of the things I want to comment today on, I appreciate everybody letting me come in a little bit late. I was in here late yesterday, but the airlines didn't want to cooperate with taking off in order to get here. And so I arrived a little bit late yesterday, and I appreciate the flexibility of everyone accommodating my schedule. Thank you. I want to recognize Natalie as the chair of the Physicians in Training section. Dr. Donna Breen is our president. Thank you very much, Donna, for being here. Executive Director Randy Glick. Thank you, everybody, for allowing me to visit today. One of the things I want to talk about and have been asked to talk about is physician leadership and shaping the future of healthcare. You know, and we're physicians in training here. Most of the attendees are, and that means you may be a medical student or a resident fellow, or even a young physician. We're always training. It's a continuous learning organization, as we all know. Remember, I think we're lifetime learners, and that's one of the things that I support, and I think most of us will as well. When I have these discussions, anytime I talk to people, what I try to talk to everybody about is thinking the healthcare heroes. All of us in this room, all of us in the audience, all of us in the SMA are really frontline workers. And we're frontline, whether we're actually in the front lines in the emergency departments or in the hospitals or the offices, but we're front lines when we stand with our frontline workers by offering vaccinations, offering research, doing the science that allows us to make decisions, developing quality treatments, having implemented studies, and even educating students, career educators in the room. That all of us are frontline workers. The administrators are figuring out how to distribute supplies, how to get testing set up, how to deliver, and infusions from monoclonal antibodies. So I can tell you, frontline, having done all that, you don't just say, all right, let's get you some monoclonal antibodies, let's get your treatment. You got to find out where it is. You got to locate it. You have to read the instructions, because these are sometimes the newer medicines for us. You have to know what you're dealing with. So all of us are heroes, and I want to thank everybody. In fact, this is one of the few times that most of us can remember, if you haven't been on the battlefield, when you're actually in the battlefield, you're putting yourself down there, your family's at risk when you go into a COVID-rich environment for the last 2 years. You never knew what you were going to do as far as taking it home. You worried about protective equipment, worried about diagnostic testing, you worried about availability of treatments and later and early on vaccines. So we've all been heroes, and I want to recognize everybody. Thank you for that. This isn't my first trip to New Orleans. I was here right after Katrina in 2005. I came here in the National Guard. You heard in the bio that Natalie was so generously discussive about. I was also the chief surgeon for the National Guard Bureau. And we set up right here at Belle Chase, Maryland, on the Naval Air Station, a tent city, a mobile clinic. We actually set one up on the site of the Charity Hospital, which is right around here. We did call it an expeditionary medical system. It was a 25-bed air transportable hospital system. We took it out of the box. It was brand new. We set it up, and FEMA purchased it from us, left it here for a couple of months while New Orleans recovered. And these are some photos of myself and a group of leaders from that 2005 deployment, early September, a couple of days after Katrina. One of those is actually a photo from Base St. Louis, which is a little bit east of here, if you recall. We also set up one of our expeditionary medical systems, and the Base St. Louis Hospital, which was destroyed by floods and more wind. More wind damage was actually a little bit east of here, and more flood damage was in New Orleans. Those of you who may not have been here at the time. It was impressive, incredible disaster. Our city here is a very resilient city, and it continues to thrive despite that history. We learned a lot from that disaster then. I'm honored to be back here in New Orleans. Let me talk about the AMA, since I'm representing the AMA as president here. One of the things you'll find what the AMA does is we like to think we're our powerful ally in physician care and patient care. So we have a mission statement, advancing the art and science of medicine and the betterment of public health. And then we have strategic arcs and accelerators that we like to focus on. Our strategic arcs are to remove obstacles that interfere with patient care, like prior authorization, which is, to me, is a dirty word. You almost can't say it in a mixed audience. We want to confront public health and improve chronic disease in America. We want to drive the future of medicine, prepare the physician workforce, physician practice sustainability, and education. So we want to make sure those three arcs are front and center in our strategies at AMA. And then we have 3 accelerators. One is innovation, where we're using technology like digital medicine, telehealth, wearable technology, robotic surgery, new technology, new treatment paradigms. You want to use advocacy, and we'll talk about advocacy here, so that you can implement this technology, these changes, and drive these strategic arcs at the federal, state, and local level, administratively and legislatively. And then you also want to embed across all of this, and we've decided to do this, and I know the Southern Medical Association also. We want to embed equity in everything we do, improve health equity, and end health disparities. It's something that's going on for centuries. It's time to take action, and we have an action plan to do that. So those are our accelerators, our arcs, and our mission statement. And I think they're pretty honorable profession we represent here. AMA leadership, I'll show you the AMA leadership. You'll see this is a diverse group of folks. Recognize me up in the upper left corner there. We have a 21-member AMA board of trustees, which is I'm real proud to be the president of right now. And you'll see a diverse demographic of representation there, that leadership. I'm honored to see that. But we also, and I don't know that I had an SMA leadership in too, but you'll find an SMA leadership has a similar group of diverse folks in it, including my picture on that as the finance chair. So thank you very much. The AMA advocacy priorities. We talked about advocacy as one of our accelerators. What we're trying to do is remove obstacles for physician practices, drive Medicare payment reform, if y'all haven't figured out. Sometimes our physicians in training, appropriately so, aren't as worried about payment reform as they are about learning their art and their science and skills. But we, at the leadership level, need to understand that we need to have Medicare payment reform so that we can sustain the practices of medicine. I'll tell you, and Southern Medical Association understands this as well. Physician pay has not really increased for 20 years. It is actually lagging cost of inflation. There's a budget neutrality that limits the ability to pay physicians more or to spend more on physicians as a group. So we're not allowed to keep up with just the index of cost of care. We've lost 1% a year over the last 20 years. So the actual physician pay is down 20% over the last 2 decades. That's the only aspect of healthcare delivery that's limited in cost. It's contained. Hospitals continue to charge more because it costs more to deliver care pharmaceuticals, and the industry continues to raise their prices to be compensated just to keep the business structure open. Physician practices are not able to do that, so we are struggling. It's one of our priorities. We want to strengthen the public health infrastructure. I think there's no question that we've noticed that in the COVID pandemic the last 2 years. We need some more resourcing in public health. We want to address maternal morbidity and mortality crisis. We clearly had that. It continues to be a problem. We want to improve access to affordable, equitable care. And we want to help physicians. We're not over this COVID pandemic yet. You all know that as well as I did. Omicron variant just brought us back to our knees again here. In my healthcare system, we've been running about 2 or 3 inpatients per day in a 2-bed hospital system. All of a sudden, we got 55 a day. And that just, 25% of our inpatient population is COVID positive and COVID sick. So it's questionable. It also reduced our ability to staff it because it affected our healthcare workers as well. So we're still needing to help physicians and the healthcare system with the COVID-19 response. What are we also doing as far as COVID specific? Okay, what we're trying to do is be the true north of COVID data. Make sure that we are the advocate for the truth. We're not interested in misinformation or disinformation. We're trying to be a trusted resource along with the federal agencies and the local agencies and things like that, the various state and national agencies. So we advocate for science-based, equitable policies. We want to reduce. We want to make sure that we reduce false information and misinformation and be a reliable source of that. I think we found that we can do that. One of the things we know is that doctors can be a good voice for science and evidence. This is on this slide, we had a picture of me being interviewed by Chris Hayes, who said, Dr. Harmon, isn't it kind of hard to practice medicine by anecdote? It really is, if you think about it, because what we're dealing with and a lot of the disinformation and misinformation that we're seeing on the internet, various social media, and some of us as physicians in some small realms have offered alternative treatments that went against the evidence. And so we were having some increase, for instance, in prescribing ivermectin, hydroxychloroquine, when the research still didn't really show that it was beneficial. And since it was unregulated and outside of a clinical trial, we might find that we could have some harm done, or damage done. And if we had harm or even success, since it was outside a clinical trial, it became anecdotal versus scientifically based and peer reviewed. So that's, we spoke against it, not to disrupt the ability of physicians to be physicians, but also to act responsibly within their purview of their licenses and their training and their scientific knowledge to prescribe these things in clinical trials where they could be regulated and documented. And if there were benefit, we can make that available to all of us as researchers and therapists. So one of the things we need to remain, and I think SMA has done that as well. We'll talk about that a little bit later in my conversation today. We want to maintain that we're a real reliable source of peer-reviewed evidence and real science. One of my catchphrases, I want to stay on the side of science. I really do. Now, there's been some problems with science in the almost an epidemic of mistrust, and that many of our patients, colleagues, and some journalists don't seem to understand that science is evolving. It's not like mathematics where 2 + 2 is going to always be 4. In science, the data may show that what was good today may have a better outcome tomorrow if you have a different approach to it. And we have an availability of gathering a lot of data in a quick format so that we can do analysis of these trials that we were talking about, peer-reviewed evidence trials, and make decisions that might change ourselves. That's not vacillating. That is moving on the side of science. If we have data that shows something can be done in a better way, we have an obligation to do it in a better way. We can't sit back and say, well, I'm going to wait just because I'm not used to going in this rapid a manner. That's one of the indications we've had with the rapidity of treatments for COVID and the vaccines. It's developed a little more fast in a more quick format than we're used to. But what happened with the vaccine development, as most of us understand as scientists, we didn't skip any of the scientific hurdles. We just skipped all the administrative burdens and the funding hurdles. Ordinarily, to develop vaccines, it takes a couple of years because you have to go for grants every couple of months. You collect your data, you have a phase 1 trial, then go to Congress, and then the H are the grant application folks, and you apply for millions of dollars to support the next phase. Well, what happened was the federal government, Congress, and NIH said, here's the money. You skip the administrative hurdles, but make sure every scientific T is crossed and I is dotted. And that's what happened. All the scientific hurdles were absolutely met and passed. The standards were there. The rapidity kind of took people by surprise. It's because we reduced all the bureaucratic hassle. But that's important to know. So we really have to understand that science is always going to be the top of the pyramid there. One of the things we talked about, reducing burdens to patient care, prior authorization. I talked about it being a dirty word. You know, I deal with prior authorization almost daily in my practice, whether I'm trying to prior authorize a prescription, x-ray or procedure, or referral to a specialist or a procedure by a specialist, another specialist, I've been a family medicine doctor. And I have to spend 30 to 45 minutes on the phone, or my nurse does, or my medical assistant, waiting just on hold to get permission to fax some data in. I mean, that's lunacy. I should be, and then I can't get, I've had some of the pharmaceutical agencies and the pharmacy benefit managers refuse to have a peer-to-peer. Will not let me have a conversation about treatment for pulmonary artery hypertension, which is, fairly, unfortunately, fairly common in primary care practices. I wanted to get a treatment for pulmonary artery hypertension, and I could not get through the pharmacy benefit manager after waiting on hold for 20 minutes, finally talking to him for 10. They wouldn't allow me to have a peer-to-peer. They just denied the claim. And that's malfeasance, if not malpractice. So that is intolerable. That's something really still, clearly that's a burr in my saddle. But it's something we need to get rid of. It's an impediment to delivery of proper patient care. We're really trying hard to right-size prior authorization. I think we can find a common enemy there. The AMA has a website, fixpriorauth.org. The more data we have, the more benefit manager input I think we can have with changing the regulations about prior authorization. We're trying also to protect patient access to care. At my level at Organized Medicine, the AMA, we're trying to protect coverage under the Affordable Care Act. We support extending coverage for Medicaid, CHIP, and other safety net programs. We've tried to ensure some legal fights at the AMA level that we want to ensure that patient protections in the ACA are maintained. We want to not get between the physician-patient relationship with local legislation. We really think that's sacrosanct, that physician-patient relationship. When a doctor talks to his or her patient, that's between them, and they make the best decisions on the patient's behalf, not according to regulation or some other fiat that doesn't necessarily have the patient's best interest in mind. And just to understand, that's paramount to what the AMA does. One of the things the AMA has also done, and I will tell you that the Southern Medical has also done this, is we've recognized a priority and a need for health equity. We really are. At the AMA level, we've recognized racism as a major public health threat. We have urged a multifaceted approach to the social determinants of health that are part of the products of structural and societal racism and racist policies. And police brutality has been recognized as a product of some of the racism. We're not trying to change the structure of the police, but we want them to have training. We need to understand in our societies that Black and brown communities have been disproportionately affected by police brutality, and we need to accept that and then set up some policies to make it better. We recognize race as a social, not a biological construct. You know, we have defined that by appearances versus the actual biology. And that's a scientific fact. So we need to understand that. We're working hard at doing that. We're trying to, and part of that, we're trying to educate people. We're trying to improve physician training on health equity. So we have on our AMA, we have some online modules. Southern Medical has some online modules, not about this, but other things too. I'll talk about them in a minute too. But we have a health equity education center so we can educate physicians in training about the idea of racism, about the social determinants of health, and helping improve health equity and end health disparities. I think that needs to be started early on in medical training so that we understand everything that's related there. One of the things that we're trying to do, and I'll go back a slide and show you, we've actually developed a strategic plan. We released it in May of this past year, 2021, to embed racial justice and advance health equity. It's an 84-page document. It generated a lot of conversations, some acceptance of some great support, some criticism we didn't do enough, some criticism that we were probably having a bridge too far, the AMA addressing social determinant of health, but it's part of our mission plan. Improving the betterment of public health. And if I'm going to address public health, I need to talk about racial equity and health disparities and improve that. So I think we've taken ownership of that. We have a 5-pillar plan there, the AMA's plan to develop racial justice and advance health equity. We embed equity in our practice and everything we do within the organization. We build alliances with other stakeholders, other medical associations, National Medical Association, National Hispanic Medical Association, Southern Medical, organized specialty societies. We want to ensure equity and innovation so that these health technologies, whether it's digital health, telemedicine, wearable technology, as robotic surgery, is spread across all communities. We want to push upstream to find out why people are in the river of disparity. They're jumping in the river. We're trying to rescue them downstream. Let's go upstream and find out why they're getting in the river to start with. So push upstream to address all the determinants of health. And we want to finally foster truth, reconciliation, and transformation to a new, more equitable healthcare delivery system. So that's kind of an ambitious plan. It's got a 3-year outreach, and we're updating it every year and kind of give you a report every year on where we are. Medical education, something near and dear to the folks attending this webinar. Physicians in training. What we're trying to do at the AMA, a lot like the Southern Medical Association, is accelerate change in medical education. We have a consortium at the AMA, has 37 medical schools working to transform med ed. And the idea is maybe to compact some of the transformation so that you can get in 5 years. Some of you might be on a combined degree path and not have to spend as many years actually getting your medical degrees, getting prepared for the workforce. But you got to make sure you don't miss any steps, that you're a full up qualified doc by the time you get through medical education before you go into your residency and fellowship training. And we have a lot of projects that are focused on innovation, technology, improving diversity so that we have our workforce in healthcare look like the patient population we're serving. That's important for us. We know that that's one of the ways to address health equity is to have physicians that look like their patients, that have the same lived experiences, have their perspective. And somehow the science shows that improves the outcome if you have healthcare delivered by someone that represents your lived experience. And you would think that it shouldn't make a difference, but it does. Somehow the patients don't communicate well. The doctors don't ask the right questions without the lived experiences. So we know that improving workforce diversity in healthcare will improve health outcomes. We need to take that as a fact, make our science work for it, and make our training represent that. We have a lot of money invested. It's $14 million this past year. So it's a big deal that we support medical schools and training. Reimagining residency. We spent $15 million on a 5-year grant to build about 8 grant recipients over the last couple of years to support future physicians in residency and fellowship. Now, this is independent of the bigger advocacy issue of improving graduate medical education opportunities. You know, as you all know in this audience, you graduate a couple thousand medical students every year, then we have PGY1 or PGY slots available for. So that puts us into a scramble there. It's unfortunate that we don't have enough GME slots for all our physicians of the future. And that's one of our big advocacy efforts at the federal level on behalf of the AMA and the Southern Medical Association. We have a medical student section and a resident fellow section within the AMA, a lot like what Matt, Natalie, and the folks here in the PIT conference, the PIT section of the SMA are trying to do. We want to make sure that you, medical students, physicians in training, have a placeholder for you in the organization so that you can be part of organized medicine, learn all this stuff, make your talents available, and let them teach you to recognize what your talents might be. So it's important to recognize that that's why we're here today, to understand the opportunity that you might have as a physician in training. We have policy making at the AMA. We have a House of Delegates. I'll tell you what we have. At Advocacy Resources at AMA, we have a medical student section page that includes links for medical schools. We have an advocacy update. We have a bunch of COVID resources. We have social media accounts. Natalie and I were just exchanging Twitter accounts for the SMA PIT account and mine at Gerald, Harmon, MD, and the AMA medical student and resident section Twitter accounts. We want to get you involved. You might ask, how can you get involved? Why would you get involved? Which is kind of the essence of why I'm here today. Well, become a member of this organization, become a member of the residence fellow section, become a member of the physicians in training, become a member of medical student sections at your institutions. Your dean surprisingly will support it. I can't speak for all deans or professors, but they want medical advocacy too, because it's their profession too. So they're teaching you to become a physician. They want you to be a leader. They're looking at self-sustainability and succession planning for themselves. Whether you go into working in an emergency room or a remote location in South Carolina or Louisiana or someplace, or whether you go into teaching at Tulane here, or whether you go into teaching at Johns Hopkins or Columbia, South Carolina, one of my alma maters. I mean, there are any number of opportunities, but you want to get involved. You want to learn to be a better doctor and a better physician. Why do you want to get at the AMA? You can get involved at the Tulane AMA chapter, which is fine, or you can do medical student outreach, but you can also get involved with the Southern Medical Association. Southern Medical Association has all these benefits as well. Networking and leadership, mentorship with medical professionals, community building with medical students. You can attend various conferences. You can build a resume. I mean, it doesn't hurt that I know that someone has been a leader in their medical advocacy or medical organization. When I look at that, and I interview residents all the time for my residency slots that I have in my small town in South Carolina, we have 8 PGY1 interns we interview. For those 8 slots, we actually interview almost 200. We have 1,600 applicants for those 8 slots. So one of the things that, in addition to face-to-face online interviews, I make judgments upon is a resume. If they've been active, if you've been active as a medical student and proactive particularly, and you've joined, you've shown that you've got some leadership. That's what I'm looking for. I mean, I'm looking for good doctors, no question. But all doctors by their profession are leaders. So I've got to pick the leaders of the leaders. One of the ways to develop that, learn how to do it, is to be active in organized medicine. Not only do you build your resume, you build your experience. It's not just a piece of paper, it represents real lived experience. So it means a lot. When I see that you're interested in health care delivery, when I see that you're interested in improving diversity or equity, those resonate with me. If I see that you've been a poster judge or something like that, that resonates with me too. If I see you've worked in a couple of overseas missions and you've worked with underserved, underprivileged nations and all, help deliver care in an austere environment, I've done all that. So I know what you're doing, and it means a lot to me. And you build relationships with other medical students across the country. You may develop lifetime skills relationships that you really never forget. You have a safety net then where you have communities of concern that you can go to. You can say, I'm having a hard time with this particular rotation, a hard time with this particular professor. You can have some opportunities and help build up your resilience and your skill sets, and it helps avoid burnout. Membership in organizations like the SMA and the AMA are all critical. What I would tell you is, as I teach, as I work with residents and medical students, what I've found is that they get kind of fatigued and stressed. I worked a rotation as a hospitalist a couple months back, around September. We were having a real peak of our Delta variant at the time, and we were just overwhelmed. We have our 200 inpatients, we had 75 positive COVID, and we were sweating. I was working 7-day shift, and the residents have an 80-hour work week, but I was working in excess of that because I was a professor there. And these young doctors were dragging. Heck, I was dragged. And I've done it for 4 decades now. So, I mean, I was physically and emotionally drained. And I saw then that they can help each other, but organized medicine as a broad picture needs to be the solution set so that we can help residents, fellows, active physician practices, medical students. When they get discouraged or physically or psychologically tired, they can go to organized medicine. We can be the answer. We can be the developer of some resources. We have opportunities to do that, and really an obligation to do.